Summit. Today's topic is Comprehensive Cancer Center in the Cloud, or C4, powered by artificial intelligence, VR, or virtual reality, and Starlink. I would like to take a couple of minutes. So my name is Saiful Haq. I am actually honored to and very privileged to be able to moderate this session with three distinguished speakers who are experts in both artificial intelligence and global oncology. So before we start, I want to take a minute to set the premise for today's webinar. The C4 concept, this is an emerging concept. It's just not only an emerging concept, it's actually going to transform and redefine what we think of cancer care today, how we think of delivering cancer care today. But before we get into the details, I want to take a moment to reflect how this C4 concept evolved with time. It was about 10 years ago, my good friend, Dr. Wilfred Ngoy, he socialized the idea of the Comprehensive Cancer Center in the Cloud when he was at Harvard. And later on, he published this concept in Nature Medicine. It was a vision, a bold idea at that time, 10 years ago, really to democratize cancer care using this C4 idea. So fast forward 10 years now, and today we are talking about really implementing this C4 idea, and we're able to do that because we have access to a lot of all different kinds of technologies. For example, cloud computing, Internet of Medical Things, big data analytics, artificial intelligence, data integrity, and many others. So we are, our discussion today will focus on many of that. But I would like our audience to really think ahead. I would like to pose this question for the audience today. Today, if you're thinking of a concept that was ahead of its time 10 years ago, what's the big, bold idea that we should be thinking about today? That seems impossible today, but that really will become a reality 10 years from today and reshape the cancer care at that time, the cancer care that exists at that time. So with that, just a couple of words about the structure of our presentation today. Each of the three speakers will take about 10 to 12 minutes each. And then please write your questions in the chat. I will take those questions and present them to our speakers. And then near the end, I will invite our friend, Dr. Wilfred Ngoy, to join us to hear from him what he is thinking as to what cancer care will be like 10 years from today. And then we'll summarize. So let me take a minute to introduce our speakers. We have three speakers. Our first speaker will be Dr. Gustavo Oliveira. He is currently the CEO of C-Level Advice. He has lots of interest, and this C4 is one of his major interests. He's also focused on addressing the urgent crisis of drug access for children with cancer, where 7,000 children die each year in Latin America due to a lack of access to essential medications and inadequate diagnostic testing. His work aims to close this critical gap and ensure access to life-saving treatments. Our second speaker will be Dr. Lawrence Gore. He is a physicist at MD Anderson Cancer Center, where he has been collaborating with clinicians in Africa and elsewhere for around 10 years. His main focus is on the Radiation Planning Assistant, a tool to support radiation oncologists and treatment planners across the world. And our last speaker is Dr. Kingsley Ndo. He's a global health leader and entrepreneur transforming oncology through AI-driven solutions. As the founder and CEO of Huron AI, he is spearheading the next generation of cancer care navigation with cutting-edge technologies to expand access to precision cancer care. So without further delay, I will invite our first speaker, Dr. Gustavo Oliveira, who will be talking about AI-powered Comprehensive Cancer Center in the Cloud. Gustavo, the floor is yours.
Okay, thank you. And I want to thank first to, uh, Saiful and Will and Steve for the opportunity to do this. Yeah. And I don't know if I was able to share the audio. I guess that's sort of the problem. But let's say, but I will talk a little bit about, a general picture of what can you guys see the presentation?
Yeah, good. Yeah, you're good. Thank you.
Okay. Therefore, I will talk about the Comprehensive Cancer Center on the cloud powered by AI. First, I will start with a quick movie that I hope you can hear and see.
Imagine a world like the one that John Lennon described. Imagine world-class cancer expertise, Harvard, Hopkins, UPMC, accessible through an AI-powered platform. Imagine affordable, continuous, and sustainable cancer care delivered worldwide. Imagine a fully integrated system, no fragmentation, no lost patients. Imagine beyond telehealth, prevention, diagnosis, treatment, follow-up, palliative care, mental health, research, and universal trials in one place. Imagine instant global access through mobile or trusted community healthcare points. Imagine geography, income, and time no longer barriers, precision medicine for all. Imagine AI-driven early detection catching cancer before symptoms appear, reducing costs, and saving lives. Imagine global specialists collaborating via virtual tumor boards. Imagine top treatment recommendations within hours, anywhere. Imagine universal access to life-saving clinical trials and experimental therapies. Imagine AI-assisted counseling, remote monitoring, and community-based support. Imagine a system that helps patients and caregivers navigate emotional and psychological challenges. Imagine a global oncology hub connecting experts with AI-driven insights and the latest breakthroughs. Imagine accelerating collaboration and innovation to push the boundaries of cancer care. You may say I'm a dreamer, but I'm not the only one. John Lennon and all of us.
Okay, that's a wish of what we would like to do, let's say, and sound like crazy, but when you start to look at the detail, it's not so far off being true of what could be done with new technology and AI. First, if we want to put a Comprehensive Cancer Center on the cloud, we need to know what the Comprehensive Cancer Center is, and we need to have the 4 typical pillars that we have in a Comprehensive Cancer Center that are clinical, research, education, and outreach. But we need to have many more components than that, yeah? And of course, we will have on the same way, on the cloud, research, implementation, education, I will go a little bit more on detail later. You need to have the whole continuum of care, to deal with the patient. But then you need to have a platform that do many more things. We need to have a unified AI platform that provide end-to-end solutions and that is optimizing every step of the patient journey. And it's important too that communicate with all the players that that need to be involved during the patient journey. Therefore, that optimization is key. Then we are trying to overcome geographic and economic barriers. Therefore, we don't wait for the patient to come because some patients are not lucky to live close to a comprehensive cancer center. Therefore, we need to operate close to the patient. We need to get out of fragmented solutions, and we need to try to have technologies and approaches that minimize the dependence on a lot of infrastructure that you need to have to treat the patient. Therefore, we also want to have personalization, let's say. We want to personalize the journey of the patient with all the omics that we can have and include all of them on the treatment and have also predictive diagnosis for those patients and have real-time optimization depending on the information that we have on the patient. And of course, what we are trying to do is to increase, survival, reduce complication and reduce cost too. Also, we are putting a lot of knowledge on the cloud. Therefore, that knowledge will provide standardization to bring high level of quality of care for treatment, and also AI may adapt to different situations, meaning not all the country, not all the underserved regions are the same, but we need to be sure that we provide quality care in all the places. Also, we need to see the patient as a whole. Therefore, we have to have a mental health approach, and we will do that with AI. Essentially, to scale this approach, we need to have, there are not enough mental health professionals, and what we will do is to have social workers or religious people trained to work with professionals and assisted with AI to deal with the mental health situation. And also, we need to have remote patient monitoring and therapy aid. And also, we need to include all the social determinants of health. Then, one of the main problems that we have in cancer today, there are a lot of late diagnosis for a significant population on different, even in US and different countries. But we need to bring to the forefront any trustable access to care. Education needs to be to the front from the people and from resources, and we need to have early diagnosis. Also, any possible means to, to get to the patient and that the patient trusts, either with community centers, religious centers, and we need to bring to the forefront new technologies that are low cost, examples, technology of point of care, portable, wearables that can be used on this type of situation and deploy very easily on different places. And we need to create collaboration hubs. If we have that, also we need to have a sustainable and self-funding mode. Why? Because that's the only way that this will work. If not sustainable, this will not work. And basically, how we will make it sustainable? Many of these AI tools that are becoming commodity will be very expensive to have or to, to buy. We are trying to put a complete platform that will give a lot of advantage to the user, and they will be able to justify the cost for the efficiency that they gain. Also need to be some, this tool can provide service to the pharma, for clinical trials, for instance, to provide a stratification of certain patients for certain clinical trials. Therefore, that can be sold as a service. And also, a big white elephant on cancer treatment is the cost of drugs. Therefore, either biosimilar need to be manufactured because some of the prices from biosimilar is 80% of the branded name, and you never will reduce cost that way. And also need to be some bulk buying and logistic to be sure that drugs don't get counterfeit if they are imported from different places. And then on the future also you can expand to other non-communicable diseases and also extend the mental health portion as a revenue source. Therefore, the project not only will survive on that way, but we want to scale this project, make it bigger every time. And will be a lot of revenues and a lot of savings that we will have with this project. Therefore, we are trying to lower the cancer cost. Early detection is fundamental because you can reduce significantly the cost of patients in stage 1 and 2 respect to 3 and 4. The efficiency that the places will gain using AI can justify the cost that these tools will have. And we need to use new and early detection approach to have low cost. And also we need to work on the drug cost. That is an important part. Therefore, when we look at these are all new ingredients that we add to a comprehensive cancer center, and all of these need to live in a cloud to be able to use it and be deployed in any place. Therefore, that's what we call AI C4. Then few examples, let's say if we have, for instance, for early detection, we will use all the different omics, proteomics, radiomics, epigenomics, genomics, biomarkers. We will put the patient on mental health support from the beginning, will be screening program and so on. But, how we get close to the patient. These are examples of some devices that we can use for point of care, and we are trying to generate a group of, a cancer detection, early detection suite that can be deployed in any place. These devices are very cheap. and beside that can be deployed and talk to internet, for instance, to Skylink or whatever internet, and can be literally deployed on the middle of the Amazon. As a matter of fact, you can see some people using it there. And, you can do tests like HPV, PSA. Also, you can start to stratify some patient only with a blood test. You can say, what is the rate for, breast cancer, or what is the, many people die still because they have leukemia and they don't know what happened and they take too long to detect that. And also DNA methylation, there are a collaboration between Johns Hopkins and this group to try to generate better and faster, detection system. An example of the type of workflow, for instance, a person can go to a community center and do a cell test. Many patients don't go to get tests because the husband, for instance, don't allow to go to the gynecologist, but they can do a cell test for most of these things. And these go to a cloud, is analyzed with AI, and come back in 1 hour and give the result. For instance, you can have HPV 16 and 18. And also we plan to have, a colposcope or an ablation device to, to very quickly that patient get on the loop, either to be treated there or put on the loop of different kind of treatment or clinical pathway, depending on the risk for that patient. Then we have all the treatment component, Therefore need to be, again, all the omics associated to the treatment. And, Lawrence and Kingsley will talk a little bit about some of the components of this, but for instance, nowadays it's very common you can do surgery with a robot. Robots are coming down on pricing, and therefore you can be in US and operate a patient in Brazil, because most of it's getting very clear that robots are better than humans, provided that the human is driving that robot is well trained. And while they are operating, the cost of the robots are getting down to $1 million and so on. Therefore, people can be trained while somebody else is, making the operation, and they have a lot of virtual reality, augmented reality, and different things, let's say. Then the other thing is...
Gustavo, please bring it to a closure as you can.
Therefore, let's go to, the revenue stream very quickly. Let's say it is important that this self-sustain with the, with the thing that I say. This will produce a lot of revenue. We can generate, in 8 years, a revenue of close to $6 billion, but also make a lot of savings. The early detection will make, significant savings that will add up to close to 1.5 billion. And lastly, let's say we look at a return in investment. Suppose that this costs $100 million. Essentially, in a period of 8 years, you go to return on investment on the order of 12,000%. Therefore, these are investment that will pay off, and hospital will take it because they gain efficiency too. Saying that was a kind of a big picture of what we are trying to do. Thank you.
Thanks, Gustavo. Apologies for cutting you short. So we're gonna bring in the other two speakers also. And thank you really for showing, really this AI platform, what it can do. We all are involved in cancer care, most of us, and we see how they all are fragmented. And when you show it on a dashboard, in everything that you showed in your first few slides, that really shows us how this AI platform can really integrate all of that. That's the beauty of this. And thank you for that presentation. You mentioned that one of our next speakers will be talking about some of the automation, and that will be Dr. Lawrence Court. Lawrence, take it away and tell us about all the excellent work that you're doing with the Radiation Planning Assistant.
Hello, everybody. Thanks very much for the introduction. I think you can see my slide. So I'm going to spend the next 10, 12 minutes talking about the Radiation Planning Assistant, which is a tool that we have developed specifically to support the clinical professionals in radiation oncology. The picture that you can see on the screen is our team of computational scientists, clinicians, research assistants, and other folk that are involved in this project. I just have one motivation slide. I think probably everybody on the call knows the motivations really, but there's a severe lack of radiation therapy access in lower middle income countries. That's what you can see on this map, where the different colors are just showing the percentage of patients who could benefit from radiation therapy, who have access. And you can see that in many countries, it's less than 50%. So that's something that would be great to be able to do something about. It's not just the access to radiation therapy, it's also access to high quality radiation therapy, by which I mean the advanced tools like VMAT, IMRT, and what have you. And, if that's not compelling enough, that, the real data that supports what we do, I think, is that there's evidence that if we could close this gap, we could save nearly 1 million lives per year, which, just think about that, it'd be amazing. And so, there's lots of reasons for this, of course, and, each group, each person can only really try and look at a small part of that. We're looking at the automation of radiation therapy contouring and planning to try and help the clinical teams scale their efforts. This is because there's a massive global shortage of radiation oncologists and physicists. It's estimated that we need about 50,000. That's a number. Training, we obviously need to do a lot of training, but you can't train that many people. It'd be really, really difficult. And so that's why we're trying to change things with AI. And so in response to that, we've developed over the last 10 years. So we were asked to look at the last 10 years and the next 10 years. So this is the last 10 years part of this presentation. We've developed this tool, the Radiation Planning Assistant, which is a web-based tool that provides contouring and planning for, right now it can do cervical cancer, head and neck cancer, post-mastectomy, breast cancer, and whole brain contouring and treatment planning. And we hope to expand that in the future. And so I'm just going to talk about the things that we've achieved in the last 10 years. I apologize for the sort of amateurish animations that I'm using, but this is just because I have a story to tell and I'm trying to do that in the easiest way. So what we found over the last 10 years that this RPA, which is AI-based automated radiation therapy, can provide these high quality, highly consistent plans. All the plans basically look the same, obviously customized to the patient. And our biggest study that we did, we looked at the head and neck, post-mastectomy, breast, cervix, and whole brain patients. And we had 31 radiation oncologists from 16 clinics, 6 countries, look at the quality of the contours and the plans and scored 80 to 90% of them overall as use as is, and the rest would have needed editing. The tool is also remarkably consistent across patient populations. For example, a recent study looking at breast contouring and planning, traditional sort of 3D planning, tangents and superclef and that sort of treatment, when it was tested on patients that included Argentina, Iran, South Africa, Switzerland, UK, and USA, almost 500 patients, 80% were used as is, which is much higher than I thought it would be for breast. So that's really nice. Efficiency, obviously we're aiming for efficiency, and we've got quite a few studies showing that we can take a plan or contouring that would have taken several hours down to sort of 10 to 15 minutes. And there's data for breast, for head and neck, and cervical cancer. And then safety, of course. And so we've got a robust registration process. We've also got a lot of monitoring going on to make sure that unusual things aren't going on. Oh, and I should have said that, I've got a lot of data here. I haven't put all the references on because that would have taken up the whole slide. So if you want any of the references and can't find them, please just let me know. We've been using these tools at MD Anderson's since, well, I don't know, 5 or 6 years probably. We use it for about 350 patients a month. We've used overall about 16,000 patients. So we've got a lot of experience in our own clinic with AI-based contouring and planning, mostly contouring though. And then we're trying to introduce the Radiation Planning Assistant that will help bring those tools that we're using to the rest of the world. So we've produced this thing. It's regulatory compliant. We've went through the FDA 510K process and got that approved in 2023. We're going to go for ISO standards 13485, which is quality management, later this year. We are live in South Africa. There's 6 hospitals there, either in the registration process or started clinical use. And this year, we're hoping to expand to Zambia, Indonesia, and hopefully Brazil, actually, and then others aligned with the IAEA efforts. Our capacity with our current system, which is very low cost, but we've got capacity to treat or create plans rather for exceeding 100,000 patients a year. And our goal is to provide the service for free for clinics that wouldn't otherwise have access. So that's the clinical side. On the research side, we hadn't really anticipated this, but the RPA is helping clinics improve their research or maybe do some research they wouldn't have been able to do. And so there's one trial that's currently using the RPA, that's the Archery trial, which is looking at AI-based contouring and planning for radiation therapy in South Africa, Jordan, Malaysia, and India. There's one trial that's opening soon in South Africa, looking at treating cervical cancer for patients living with HIV and the different ways of doing that. That will use the RPA. And then there's another trial that's under development that we're hoping to be able to contribute, looking at lattice therapy. We're also helping team improve the level of scientific publications that teams are able to do. So we recently did a PubMed search, and it looks like only about 2% of papers on auto-contouring in radiation therapy come from sub-Saharan Africa. And most of those are people that have collaborated or are collaborating with us. From our point of view, I think the most exciting ones are ones where the teams have done their own, we're not doing the work and collaborating with them. They're doing the work and testing the tools and looking at how does the RPA or automation or AI work with their local populations and clinical approaches. So there's a paper in the Journal of Global Oncology from the Ocean Road team in Tanzania that looks at this. And then there were a couple of presentations at the recent South African medical physics meeting about the same sort of thing. And we're looking to help more people. So please contact us if I'm interested. And also in terms of funding, we received quite a lot of funding from the NCI and CIPRIT and Wellcome in the early days of the project. And now by making the RPA infrastructure available, we'll be able to help other places get their own funding for research. So this is the last 10 years where we've got to right now. So this would normally be the end of the talk. So there's an enormous shortage of radiation therapy staff in low and middle income countries. Automation can help. Our tools are already in use in our own hospital, and we are making them available through the RPA. Our goal is to do this for free. And I'll talk a little bit more about that later. And we're also realizing that perhaps we can help teams scale research and other efforts. So what's next? That's what we've done in the last 10 years. What are we going to do in the next? There's some obvious things that we know we can do. We just haven't done yet because there's only a certain number of hours in the day, I suppose. So we can auto-contouring and planning for more treatment sites. So here you can see auto-contouring for the upper abdomen. We've got prostate, we've got breast, but also auto-contouring for gross tumor volume. So we haven't done that so far because we hadn't had tools that were sufficiently reliable to be released into the clinic. But that's changing. What you can see on the screen is work from Jinzong Yang and his group at MD Anderson, where they are managing to auto-contour GTVs for head and neck. And it takes advantage of multimodality images if you have them, and if not, it will use what you have. We're also starting to look at how these tools are not just, we've tended to focus in the past on just contouring or just planning and haven't combined them that much, although we did do a bit for post-mastectomy breast and for cervical cancer. But really, that's what's next. So we're going to be looking at full automation with people involved at the beginning and the end. And there's just an example of that shown on the right-hand side for prostate, where that's a case where all of the contouring and all the planning was done without human involvement, except, of course, at the start to tell the computer what you wanted, and at the end to review and make sure that it did what you asked. That's the planning side. We're also quite deep into AI-based peer review. So once you have a plan, how do you know if it's any good or not? And so typically you might show somebody else who has experience in that, but you may not have that person available. And we're finding or showing that AI can fulfill that role. And what you can see on the screen is an example for cervical cancer, where we had a clinical plan and then a predictive plan. So we're using deep learning to predict what good plans should look like, and then flagging any differences. and then showing that the plans can be replanned to give a better overall plan. And that's working out really well. We expect to try and deploy that for sure in the next 10 years, but more likely in the next couple. Also training. So we haven't had too much involvement in training, but we're starting a project. We're a couple of years into this, of developing what's tentatively called the RPA trainer. So it's basically a flight simulator for radiotherapy training. So if you're starting like VMAP planning, for example, how do you know if it's a good plan or not? And so we're trying to help improve ways of training people on that aspect of radiotherapy planning. And so we've got this flight simulator where the little movie that you can see on the right is showing where the user has asked the computer to improve the parotid sparing, and it's sort of simulating what the sort of interaction between the physician and the dosimetrist. And this can happen almost in real time, so it can really speed up the training process. So what's next? So this is probably almost the most important slide, I would say. So we're hoping obviously to change the map that I showed at the beginning. So it goes from all these areas with poor access to where everywhere looks the same. You can have the same treatment anywhere. Quite honestly, I think for us, technology is no longer the bottleneck. And so currently I see 3 major challenges to make this whole project a success. The first is expansion. We need to expand. Right now we're in South Africa. We've got other countries lined up, but we need to really accelerate that expansion. And so legal assessment and making sure we don't break any local laws and that sort of thing, that's a major hurdle or bottleneck for us. The next is also related to accelerating deployment. This is implementation science. The RPA is a multidisciplinary tool. So you've got contouring, you've got planning, you've got physicists, you've got oncologists, you've got therapists, dosimetrists, lots of different people involved. And that has an impact on implementation. So we really need to understand that and create ways to really make it smoother to accelerate deployment. And the third is sort of related to what Gustavo was saying towards the end. We need a sustainable funding model. Our annual running costs are actually quite low because now the technology is such that these models, if you have the data, are not, we know how to do this. But our annual running costs with our current model, the way that we're operating things right now, is about $1 million. And for that, we can do at least 100,000 patient plans a year. So that's, it's quite cheap in that sense, but we do need to find that money so that we can offer this for free to clinics that wouldn't have access otherwise. We're looking at possible donors, or I don't know if this is a real term, but I've been calling it Robin Hood approach, where, maybe we charge private clinics in order to offer it for free to public clinics or something like that. But this is where we're at. I'll be happy to take questions at the end, and thank you very much.
Thanks, Lawrence.
Yeah.
And thanks for the amazing work that you and your team are doing. The big picture that I see is, as you said, that there are about 70% of the cancer will be in the LMICs, and 50% of those patients don't have any access to it. And your work will reduce the bottleneck, scale access, and bring consistency and high quality. And particularly, you showed some work about cervical cancer, and we know there's a major incident cancer all over the LMICs. So I'm sure there'll be a lot of questions at the end. Let's go to our next speaker, who really has been developing a lot of AI solutions to help our physicians with decision making, and then also help our patients to navigate from end to end across their entire journey, particularly in their survivorship. Without wasting further time, Kingsley, the floor is yours. And Kingsley will be talking about how AI can enhance long-term. Sorry, your AI co-pilot. There it is on the screen.
Yeah, thank you so much, Saiful, for inviting me, and thank you to the Global Health Catalyst team, and thanks to my panelists that have just really knocked it off the block. So I'll be talking about more on the medical oncology side and the treatment management circle, and I would like to start with this. I'd like to start home in the US, and then we'll look at what happens globally. So 70% of US cancer patients would go to a community oncology center. And if you compare, the average community oncology center to, for example, Lawrence Court, who is at Ebony Anderson, there's a 20 to 30% mortality gap. So people who go to the academic level cancer centers do have much better outcomes. And I like to exemplify this with the story of Amy, who is not her real name, who's a mother of 48, who is a mother of two. She's 48 years old, lives in Alaska. She was diagnosed with breast cancer, went to her community cancer center and, started treatment. And when she came to Seattle, she wanted a second opinion at Fred Hutch, and they found that the treatment protocol that Amy was getting was kind of an older protocol, and there were other options where it would have been twice as effective as what she was getting. And so community oncology centers in the US, handle 3 times more patients than academic centers, and it's very hard for them to keep up with the ever-changing and evolving treatment guidelines. And then when you look at other parts of the world, like in Africa, there is 1 oncologist to 3,000 cancer patients. And in Latin America, there is 1 to 1,000 cancer patients. So this is not just a problem at home, but it's also a global problem. And so at Huron AI, when we look at the clinicians or the oncologist point of view, we have developed an AI copilot that helps the oncologist to sort of like solve some of these bottlenecks. So for example, our AI agent for the clinician-facing side retrieves real-time data, so unstructured data from patients' notes, and runs through multiple treatment plans in real time that are kind of up to date. And this can be done through voice, clicks, or basically just a conversational platform to produce the most latest guidelines that are personalized for the patient. And not just that, it can do a lot of other things like, note-taking, referrals, things that could be a little bit repetitive for an oncologist. And just like Lawrence mentioned earlier, multidisciplinary care. So think about this AI copilot as an oncologist's best buddy, or their BFF. So imagine the copilot in a multidisciplinary tumor board meeting, taking all the notes, plugging into the latest, any relevant new clinical trial results or research that could alter the course of care for a patient, and helps multidisciplinary teams to come to a unified decision quickly. And then for patients need a lot, and we'll go to that in a second. But basically, patients need navigation from the time they are diagnosed, understanding their diagnosis, understanding and predicting the kind of journey that they're going to go through in the healthcare system, understanding the kind of support that they need, things like nutritional support, financial reimbursements, insurance, there's just a lot that patients go through, especially after receiving such a heartbreaking diagnosis like cancer. It could be very overwhelming for both patients and their caregivers. So this is just an example of one of the things that the Copilot can do. And obviously, the technology is moving very fast, and we're building building very fast as well. But here you can see that a patient summary was automatically made for a clinician to see, okay, this is the patient they're seeing, and they're looking at what kind of treatment options to provide this patient. And you can see that on the right side, there for this breast cancer patient, there are. And this avatar is just an avatar that can be customized on our platform for the doctor as their digital oncologist. But here you can see that the different levels of treatment, or the different options of treatment, is produced, and this is run by and with references and rationale and explainability. So essentially, the output is coming not just from unstructured patient data, but also coming from complex guidelines such as the NCCN, and it runs on other professional network guidelines to produce the most recent guideline concordant care for the patient's specific condition. So this is an example of like a conversational platform where you can do data retrieval. You ask it a question. Here is me sort of like testing it, and you can see I told it to pull out a patient's plan. I'm sorry, that went too fast. And it pulled it out as well. So think about like this digital oncologist as someone you're talking to, and it's responding to you either through typing or through voice. And then when you go to the patient side, like I mentioned earlier, there are so many things that the patient will deal with from the point of diagnosis, even just understanding the gravity of the diagnosis. What is stage 2? What is this? What is ER positive? Patients are overwhelmed with a lot of information. And a lot of times when they receive the diagnosis, they are already blank, and whatever the oncologist is telling them, it's almost like it's, just kind of passing through a blank space, because they're trying to grapple with such difficult diagnosis. But patients would have to think of a lot of these things and this is by no means exhaustive, but you have to think about a lot of the different specialists they're going to see, the labs, they're overwhelmed with a lot. And so the navigation component of this co-pilot is to ensure that patients have a very simplified, they're empowered, and they just have very simplified information that can really help them navigate through the healthcare system, navigate through side effects, symptoms, psychosocial support, all the gamut of things that patients would have to navigate. And so when a patient, and so to make this even more robust, there are several things that our co-pilots run on to also support doctors, and that is all the data that patients produce. And patients produce a variety of data. The data set is from the social determinants of health data, genomics, imaging, and all the gamuts of data that patients should produce from the time they are diagnosed, or even before their diagnosis. Like, I mentioned social determinants of health. All this feeds into the system to ensure that they can get the tailored support that they need, not just from their oncologists or cancer navigators, but also also empowering them to take action as they navigate their care. And, everyone have sort of been mentioning, what the future is of clinical oncology and healthcare in general. And what I see is a symbiotic relationship between data, AI, and clinicians. So just like, Gustavo presented in his presentation, and Lawrence, you can see that it's literally really going to that point where in real time, clinicians would have to, as a matter of, it's just like, they just have to do that at some point to provide the best care for a patient, the best, most personalized precision care for a patient. And to do that, you need a lot of both longitudinal data, historic data, and AI that is run on factual information, most up-to-date guidelines, relevant research that can alter the course of care for a patient. And so these are the wins of, this is what we envision the wins of the stakeholder should be. And the stakeholders are mainly the clinicians, patients, the cancer centers, and plus or minus insurance companies, the public health system in general. But essentially, we want clinicians to have less cognitive overload and provide more precision, personalized care that is in line with the most up-to-date guidelines and in line with the patient's condition. And then for patients, they need, like I said, just faster personalized treatment and navigation throughout the system. And for cancer centers, want to see, equalized or sort of like equitable academic level care, you want to see reduced workload by the clinicians, not just the doctors, the nurses, and everyone involved in care. They want to improve their reputation. They want to reduce operational costs. Those are the kind of things that will be wins for cancer centers. And obviously, I think the key thing is democratizing high quality precision care to everyone, everywhere. So thank you so much. This is our team. I don't do this alone, and looking forward to the questions and answers. But before I go, I'll say one of the things that we've done. We're currently working with Kenya. We're working with Kenya because they do have plans to expand this solution nationwide. We're also working with UCSF Helindila Cancer Center, where we're trying this AI co-pilot on brain cancer patients. And as you know, a lot of the major academic cancer centers here in the US, they do have affiliate cancer clinics. For example, in the case of UCSF, they have 54 affiliate cancer clinics in the state of California. And some of that is in rural California. And that's why they are very keen to using this for patients that sometimes often don't even speak English. Most of them will speak Spanish. And then Huron AI contributed significantly to the President's Cancer Panel Cancer Navigation Technologies, which was submitted to President Biden last year, and have shaped some of the AI cancer policies here in the US. And we're currently engaging with centers like Johns Hopkins and Huntsman's Cancer Institute in implementing some of those recommendations. Thank you.
Thank you, Kingsley, and thanks again for the amazing work that you and your company is doing. Maybe if we can have all the presenters on the screen, that'll be great. If you stop sharing, and maybe can we have the bold, everybody in big picture? Okay. So there are a lot of exciting questions, and a lot of them. We have about 12 minutes. I would like to try to maybe summarize a few questions. So first, there's a question came from Val Torres. Dr. Torres, you asked a question to the speakers. You have a large network of clinicians and if your own platform, will everybody be willing to collaborate with you? And my answer, I think everybody will say yes. Yes, I see the heads nodding. So I'll say that yes, everybody will collaborate. Donna has a question for Gustavo. Who will buy your system? Will it be CMS, United Healthcare, or VA?
The idea is to make it affordable to everybody. We are planning to go to the public system. The public system will have things to reduce cost. And in the private also, they will pay a little bit more. But again, this system, as you know, Kingsley was showing, you gain efficiency. Therefore, that efficiency justifies the price. And also you can give some other thing on top of that, cheaper drugs, access to drugs that you may not access. Therefore, you can provide a lot of savings that, they will, cover the cost of the tool that they are trying to implement, because they will gain efficiencies all over, and yes, will be a lot of rearranging of the workforce. That's the reality, but, certainly there will be a lot of cost saving.
Thanks, Gustavo. Kavuma has a question for everybody. And I'm trying to summarize the questions. Some oncologists, medical physicists, and other professionals have reluctancy to adapt the AI solutions. Other than just continuous training, what else can be done?
Let me, I think I'll take this. So one of the things that would really kind of espouse trust among clinicians is continuous sharing of results, publications, showing actual hard data, because a lot of times, there are lots of digital health solutions and people just have questions on, oh, is this changing anything? Or is it even adding more work? Like for us, for example, when we first piloted, we had, just on patient satisfaction, and this was just a feasibility study, it was 95%. Doctors had reduced, so for example, doctors at Rwandan Cancer Center, they will usually do follow-up calls to patients. They would have their phones inundated during dinners just to answer patients' calls on side effects, but that reduced by 50%. And in the work we're doing with UCSF, we're basically showing that if we use Huron AI's platform plus a community oncologist is fairly similar. The plans that is going to emanate for particular patients is fairly similar to what UCSF will do. So publishing those kinds of results, I think would really help. And then the second is rationale, so explainable AI. So for example, the demo or the mini demo I showed that it comes with a rationale, where the references are, for example, in NCCN, where doctors can actually go and check if they're not clear on certain things. And explainable AI is a whole field that is evolving from this question where, especially in health AI, where clinicians act with evidence. And it's really important that we can build tools that are not just black boxes, but comes with explainability.
I will add a couple of things. One is safety. I used to run a group of 300 clinics. If this tool were available, most of the errors that there was can be predicted, checking consistency between notes of people and so on. Therefore, safety can be improved a lot with this. Second is diagnostic. A lot of false positive, negative, whatever way you want to say it. AI is helping a lot to the diagnostic component, and also is helping to people to gain access. Most of the places are fragmented, and a patient go from one line to the next line to the next line, and they sacrifice the survival, during that time. Therefore, this will, optimize all those things in order that the patient don't have to even deal with that. It can be done automatically.
Thank you. Lawrence, you want to add anything to that, or shall we just go on to the next question?
I think you can go on. I agree with everything that everybody said.
Thank you. Yes. All right. Appreciate that. Donna O'Brien had a question for Kingsley. What is your source on higher mortality in the community?
So it's a paper that was published in the Journal of Clinical Oncology. I think this paper was 2021, and I can actually share that. Donna, if you can send me an email, I'll share that with you.
And there are a paper from City of Hope that essentially show that if you are close into a comprehensive cancer center, your survival is higher. That paper was by City of Hope. It may be biased, but let's say, but it's, data. No?
And I'll add that it's not all community oncology centers that have this mortality gap, but in that paper, they picked, it was basically a random sampling. Obviously, there are some community oncology centers that are par with some academic cancer centers, but this was sort of like on average.
Yeah, the one I say is looking the distance to live close to a comprehensive cancer center. I will send.
From Pablo Castro Pena to Gustavo, how can indigenous people be connected so that after remote diagnosis, they can access treatment where they'll have to travel? And how does AIC4 contemplate access to this therapy facilities?
That will be an evolving thing, but certainly, on the long run, machine will run by itself. On the long run, let's say 10 years from now, yeah? Will be an evolution. For instance, the Danish people, they have a tertiary schema that India is trying to adopt. For instance, they have, a primary, secondary, and tertiary center, and they have pretty good Linux, but basically they treat most of the type of case close to the patient. Therefore, they create an infrastructure that, is supported for a big center at the end, but Linux are getting down in price. Linux will go down in price, and Linux will become more automatic. Yeah, therefore, on time will be machine closer to the patient. At this stage, probably, radiotherapy is the bigger bottleneck because of that lacking. But I can see on 10 years that will be all machine driven. Pretty much you will not have, to deal with therapies or symmetries or whatever. That's it.
One other question, but I wanted to say that there's a lot of comments about your presentations. All the speakers, how wonderful your presentations are. Lots of fantastic comments about how great your presentations were. So I want to thank you for that. Lawrence, maybe we'll ask you a question. So AI is revolutionizing cancer care. Can it also introduce new biases in diagnosis and treatment? And how do we ensure that AI models don't reinforce existing global health disparities?
Yeah, so that's a very good question that I get asked fairly frequently, I guess. So I mean, the only way to make sure there's no biases is proper testing on all different populations, and we've tried to do that a lot. We try to get data from as many places as we can. That's actually remarkably difficult to do. So the training often is essentially multi-institutional in many cases, but the testing is really important. At least for radiotherapy, we found this doesn't seem to be too much of a challenge. Diagnosis, I'm sure, is going to be, I imagine is a bit different, but really be not just publishing based on single institution data, but looking at multi-institutional, like multi-country data. And what was the second part? How to make sure that we don't make things worse instead of better, right?
Sure.
Yeah, so that really, I don't see us making things worse. But definitely we have to make sure that the tools that are there are available to everybody so that they can use them. I think that's the key. And that's what we're trying to do, is take the tools. We've ended up putting these tools into our own clinic, and that is really useful for us because we have the clinicians next to us to tell us what they like and what they don't like, and then making that available elsewhere. It's really the access to the tool is probably the key thing here.
Thank you. I want to take a minute. Will, I know you are active in the chat. I would like to invite you to join us, please, and maybe share some thoughts as to where do you think will be 10 years from today? The big question that we started here.
All right. Yeah, no, thank you, Saiful. First of all, I mean, I'm super excited, just to hear Gustavo present that vision. And, obviously, like I mentioned in the chat, Lawrence, you are a true pioneer. I know I can just imagine the impact of this in these years to come. And Kingsley also always inspired about where you're going. And really what I like about what you're doing, Kingsley, is that you are not only doing this in lower mid-income countries, you're showing that that can be done here in the United States. And I think with the new government, as we think about win-win approaches, it's really going to be important for us to say, okay, if something is benefiting somebody in Kenya, how does it benefit somebody in Alabama, right? So that's really powerful. Yeah, and my only comments in terms of 10 years from now, I mean, I actually flirt with the idea that we're not going to need medical oncologists, right? I mean, but you have to kind of transition this in a way that's win-win. And that's really going to be disruptive. We may not agree now, but that's the truth, because we know NCCN guidelines are already there. And so we have to start thinking about training the workforce of the future. It may mean that we need to train as residents very differently, not 5 years, but maybe 2 years of doing stuff. But I think, the last point I will make is just that, coming up at the Global Health Catalyst Summit in June, there's going to be, and also we are looking to really get additional funding into this initiatives. You may have seen President Trump with Stargate, Cancer Moonshot. Before that, Biden has been talking about, how can we take the Cancer Moonshot globally? The vision that you guys have presented today is really the kind of way to democratize access to care. And I think we can work by taking into advantage all of what this new US administration, but also the Biden administration has been focusing on. And so at the summit, we're going to be talking about the global cancer funding to scale these kind of approaches. The next 10 years are going to be focused on scaling some of these technologies. The tools are already there. Most of the tools are there. We're obviously developing new ones, but how do you integrate that, like Gustavo was showing, right? So across the cancer care continuum, from prevention all the way to the end, survivorship and palliative care. And then, just Enid also mentioned that, having a lot of hubs. We already have, Dr. Beatrice in Ghana. We have Tanzania government. They're really interested in the C4 concept already. So this is something that governments already bought into. And this is something I know in Brazil, Gustavo also wants to extend that there. So the future really means scaling this, really investing, collaborating, like one of the person in the audience asked, really collaborating to make this become a big reality. I'll stop there.
Thank you, Will. I was going to leave the audience with a thought similar to what you said. You've summarized it beautifully. The question is, how do you scale it globally? And when you really start to implement it, what are the barriers we may face? Will this be technological? Will this be data sharing? Will this be financial, regulatory? So those are the things we'll start to face, right? And what will really define the next decade of AI-driven oncology? I know we all are thinking about these things, and there have been exciting presentations by all of you. On behalf of the GHC, I want to thank our speakers, for your fantastic presentations and taking the time from your daily life to come here on a weekend to spend the time with us. I really appreciate that. And I also want to thank all our participants. There has been, my goodness, an incredible number of you, participating in it, and really looking forward to working with all of you in the future. Now, please come to Global Health Catalyst Summit in Boston and help us really implement this fantastic concept, and also help us to dream what it is, the big next bold idea that we can come up with that will shape the cancer care 10 years from today. With that, thank you all again, and have a wonderful weekend.
Thank you.